Well, welcome everybody to the third episode of the Coronary Corner. Pleased to be here with my colleague Manos Brilakis, and today we have a great topic that we'll be talking something very dear to you, Manos. We'll want to talk about the role of CT for CTO PCI.
Yes, absolutely, Yader, and it's a super exciting area, as you know, an area that we are both very passionate about, and an area that has been evolving very rapidly, and I think now it's becoming more and more mainstream on day-to-day practice. But I know we talked in the previous episodes about the general role of CT for planning PCI, the importance of collaboration with images, but I think CTO is the area that brings all these topics together.
No, I agree, and I think as we've talked, I think CT is clearly very helpful, something that you can use for every lesion, but it is in not surprisingly in those patients that have complex coronary artery disease, whether that's calcium, osteal lesions, bifurcations, and CTOs, where I think in those complex lesions where having additional information may help. But maybe Manos, maybe tell us and our listeners, what is right now the present standard of care and status quo on CTO PCI? I think still one of the toughest lesion subsets out there. We know that in some of those registries and trials with expert operators, they're pretty good success rates, but that's still not the case for most operators out there that are tackling CTO. So what's this right now, the state of CTO PCI, and where does CT fit into this?
Yeah, and you're absolutely right. We have all these registries that have experienced operators like Progress CTO, the Euro CTO, LATAM, where you have actually high success, 85 to 90%, lower complication rates. But then if you look at the registries for the unselected NCDR, general BCs registries, so we got those registries, the success rates are remarkably lower, more in the 60% range or so. So there's clearly a gap between the more experienced operators doing CTOs and the less experienced operators. And this is actually an area where having extra tools like coronary CT for planning guidance patient selection, this can help potentially bring the gap, narrow the gap, and bring the operators, make them better at both ends of the spectrum, actually. And I know, Jared, that you've been phenomenal in leading that area of CT guidance, and there is the document from SCAI about CT guidance for guiding PCI, and it does have a small portion on CTO PCI. But and you have a lot of experience on this. What has been your thought? Who would be the ideal person to use CT on? Who are the patients who have CTOs who should get it? Should it be everyone who have a CTO? Should it be the failed cases? Should it be the complex cases? Who do you think will be the best candidate for having CT when they have a CTO?
It's a great question. And for many things that we've talked in the past couple of episodes, and I'm sure we'll talk in others, for CTO specifically, what's interesting is that of all these fields, that there's a lot of questions and interest in the opportunities with CT. For CTO, there's actually a randomized trial. There's the CTO PCI trial published in JACC Interventions, I think in 2021, that it was a positive trial showing that if we use CT proactively in these patients, we will improve procedural success, a signal towards also fewer complications. So you could argue that of all these things that I think there's some degree of enthusiasm and hype and interest in using CT, of all these things, some of them we're still generating the data. Here, we're sitting on a randomized trial. So if we want to be evidence-based, I would argue that we would want to use it in most patients, because this is not my opinion. This is actually evidence-based suggestion that by using this, we can do better for our patients. So I would argue that we should be using more of it.
Yeah, thanks, Yader. And you're right. The CT-CTO trial is a very important one. 400 patients from Korea randomized to CT guidance or not. And overall, there was significantly increased in success. And there was a trend actually for even less complications. But on the subgroup analysis, when you look at who actually benefited the most from getting the CT guidance, they were the more complex CTOs, the J-CTOs 2 plus. The less complex CTOs, there wasn't that much of a difference. So one might argue that, hey, it's the more complex ones that you get more of the benefit. And maybe that's because the investigators in the study were experienced, so the success rate was in the upper 80s, actually 90 plus. So it was very high, especially for these less complex lesions. But I'm with you. I think CT could help a lot at any stage, and even in the diagnosis of a CTO. And we are now having some patients sent to us, as you have seen as well, who did not have a diagnostic angiogram, but come directly with a CT instead of a diagnostic, and come directly for a CTO PCI without having a diagnostic test.
I agree. This has been a game changer, and it's a rapidly evolving field. I mean, patients with CTOs have been having CTs for a long time, but I think what right now we're seeing is that I think the status quo was that we would say, oh, there's severe CAD on the CT, and this patient needs an invasive angiogram. But now that I think our mindset over the past few years has been evolving in that we want to interact with the data, and that we're like, well, what is the complexity of that lesion? Is that actually a CTO? And once we understand the data and interact with that information, now we can say, hey, my next patient in clinic has a CTO, and we can actually look at all the features that we're interested to understanding the complexity, where there's even like JCTO scores for CT specifically, and we should talk a little bit about this more. But you can pretty much have the whole understanding as you're talking to the patient and decide the complexity about what sort of procedure you're getting into. To me, I'll just my personal story on this. To me, besides, yes, before we even get into the depths of procedural planning, to me, this issue of using CT for diagnosing CTO and diagnosing that non-invasively, and therefore allocating that appropriately, it's just a tremendous unmet opportunity that can probably improve the experience for patients, for operators, for everybody. Think about any other procedure that we do in cardiovascular medicine, particularly procedural fields, right? If you have severe aortic stenosis, you go to the operator or surgeon that is experienced to deal with TAVR, for example. If you have the echo that has severe mitral regurgitation, you're seeing the person that will deal with a MitraClip and so on. But in coronary disease, patients unselectedly have stress tests and nuclear stress tests and the butyrate stress tests and other things, and therefore we don't really know what sort of phenotype of coronary artery disease they have. But CT totally changes that, right? Because now with the CT, you actually know, is this single vessel disease, is this multi-vessel disease, is this severe disease but it's not obstructive, or is this actually a CTO? And if it's a CTO, therefore you should say that patient should be in your clinic, and therefore they will be with folks that are trained to provide the best advice. That doesn't mean that all these people need to have CTO PCI. They may need bypass, they may need medical therapy, but therefore the patients that have CTO or complex coronary artery disease are allocated to coronary artery disease clinic, where they can get consultations on this issue. So I really think that CT creates a great opportunity for both the physicians and the patients, importantly, to really provide that opinion and consultation on the management. I don't know whether you share that same enthusiasm that I have about this, but I really think it's an opportunity for our field in coronary disease.
No, I do agree with you, and it's the same thing as any other complex PCI. There's one caveat that CT sometimes may have a little difficulty in differentiating between CTOs and subtotal occlusion, especially on the short occlusions, although there are criteria that can help you differentiate that. But I agree with you that knowing that you have a CTO, who have patients coming from other states, specifically because on the CT, they have had a CTO, they get one procedure, it's both diagnostic and doing the PCI. So they save the second procedure, they go to a center and an operator who is experienced in doing that. And you're absolutely right that this can change the game and make streamline the patient referral and the patient experience overall. Now, there are some limitations to CT, which we'll talk later on when it comes to planning, like the collateral, some things that angiogram remains a little better. But CT does provide a lot of information to help plan. And this is maybe a little different than what we do on the regular planning for the non-CTO PCI, where you have the MIPS and everything else, because you get the collaterals we don't see. But we have seen that starting from the proximal cap, the occlusion length, the occlusion composition, is there a calcium or not, distal vessel, these things can be very, very well seen and can be very useful. We had a case today, actually, in which we thought it was going to be a 100 millimeter CTO, super complex, primary retrograde. And the CT showed it was actually a 14 millimeter, a very short CTO in the mid RCA, and the rest we thought was occluded and collaterals was actually the main vessel. So there are many cases like this where the CT makes a huge difference in how we approach the lesion and how we plan for it.
I mean, I agree. I mean, when is more information, particularly if it's non-invasive information, potentially more helpful to enhance what you're getting into? The other thing that I think it's important to underscore before that, besides diagnosis, is shared decision making and procedural risk. I think it's. I know we're going to talk about procedural planning, but I also think this is critical, right? Because I remember this from your book, right? Remind me if this is there, but I remember one of your earlier iterations of the book will say do not do ad hoc CTO PCI, right? You want to plan, you want to look at the angiogram, you want to set up yourself for success, right? And the something that is happening now with CT, and I think you alluded to your experience that you're getting a lot of referrals of folks that are coming to your clinic just on the basis of CT, is that therefore, as you just pointed out from your recent example, you know the occlusion length, you know whether it's tapered or ambiguous, you know whether it's calcium, you know how long it is, you know is it a bifurcation. You can characterize all these features. So therefore, you can have that conversation with the patient before you go to the lab and you say, look, let's pretend this is a single vessel CTO. You say, hey, this is we based on the CT, we anticipate we're going to do the angiogram, but we anticipate that we're going to see a RCA CTO. And based on all the features we're seeing, this appears to be, let's say a low complex CTO. It appears short, it appears tapered, and we anticipate that it's going to be a procedure that will have a good probability of success with X estimation of risk, and vice versa. You could say, hey, this is a super long CTO, ambiguous, looks like there's a lot of calcium. So I think you can have those discussions of the anticipated, procedural success probability and risk before you get into. And therefore, I think this is a very transformative time for us, because therefore now you can embark in that procedure. And I don't think, in my view, that's no longer an ad hoc CTO PCI. This is a planned CTO PCI that you've discussed the risks and benefits of the procedure on the basis of the CT. And now, therefore, I think you go ahead and do your dual axis, and you've had a conversation about those issues, and you just go ahead and offer the procedure because you've had a conversation. I don't know whether you've had that experience as well.
Yeah, no, I completely agree with you, Yader, and it does help. I mean, regardless, I mean, the CTO procedure should not be an ad hoc procedure, and that's regardless of a CT or not. Even if you do a diagnostic angiogram, then still you should stop and then have the conversation with the patient and the family, and then bring them back for many reasons, not only for the patient to be better informed of the risk benefits alternatives of the procedure, but also for yourself to plan the procedure better, for the cath lab to have the time to plan, to not have to squeeze this patient and try to rush things through, or have the other patients be delayed and be upset and waiting in the waiting room. So it should be a planned procedure. And you're right that the CT makes this much more easier for this to be a planned procedure.
I could talk about this issue of triage for a long time, because it's something that I actually feel very strong about. That is one of the primary benefits of using CT for general PCI guidance. And as you alluded, this is something that we also touch on the SCAI SCCT consensus document. But before we shift to the planning part, which we should do soon, is the last element is, as I think there's a lot of diversity in our labs, in operators, in different skill sets. And this CT, okay, now you've diagnosed a CTO. You've had the conversation with the patient that, yeah, we want to do. Now you can use this to say, hey, this is a very complex procedure. It's a long calcific CTO. You can say, I want, therefore, on the basis of this CT, for this patient to be scheduled Monday at 8 a.m. Let's say if it's somebody like me, younger stage in my CTO career, I could say, hey, maybe I want to consider doing a dual operator rather than single operator. I don't want to do this at the ASC. So I really think that the CT, that pre-procedural plan, even before thinking about how you're going to tackle the CTO, can really help set yourself up for success, because you can look at that information and you can say, no, 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 this is not my 3 p.m. case late in the day. This is a case that based on this information, I want to have A, B, and C tools. I want it to be done at this particular hospital early in the day. I think it can really be helpful for planning.
Now, could not agree more with you. This is very important, but also we do have various ways to estimate the difficulty of the procedure, the risk of complications, the chance of success. And it turns out the calculation based on the CT is more accurate than the calculation based on the angiogram. There are several scores like KCCT, CT-RECTOR, and there were comparative studies showing that actually your predictive capacity, the AUC, was actually higher if you did the planning based on CT. So not only you are prepared, but you're prepared potentially even more so than you would be by doing an invasive angiogram. So completely agree with you, Yader, in terms of the use of CT for planning. It's not only that it tells you there is a CTO, but it is actually more accurate than the angiogram in predicting the success. There are several scores, such as the CT-RECTOR, KCCT, several other scores that are based on CT, and they have been shown to be more predictive of success than the angiographic scores. And now with AI, there are some other new methods that you can actually predict the success of undergrade wiring. One of our fellows developed this model, freely available. And there's some other machine learning techniques that you can give you a very good estimate of the chance of being successful and the chance of having a complication. So CT can help you be more accurate. So when you discuss with the patient and tell him your success chance is 87%, your complication is 2.5%, can be fairly accurate in predicting what could happen during a procedure.
And Manos, I think you just mentioned some scores that people may or may not be familiar. I think most folks will be more familiar with the angiographic based scores. I mean, there's KCCT, J-CTO, adapted for CT, as you mentioned, the RECTOR scores. Can you elaborate what are those features that you're looking at the CT that people should familiarize that you can actually obtain with CT and maybe potentially with more robust data?
Yeah, absolutely. It is the same components to a large extent than the ones on the angiographic scores, but CT can be actually more accurately. Specifically, the number one thing for CTOs is the proximal cap. Is the proximal cap clear? Do you understand when the vessel starts or not? And the CT can show you there's the side branch. This is where the vessel continues. So it is actually one of the methods to overcome when you have what's called ambiguity in the proximal cap, where you don't really understand where the occlusion is starting. So that's one thing. The second thing that CT is better is on the length of the occlusion. The problem with the angiogram, even with dual injection, is sometimes you don't give it enough time for the contrast to come through, so you tend to overestimate how long is the occlusion. Whereas the CT, there is more of a steady state, so you can tell more accurately this is the actual length of the occlusion, and CT is much more accurate than not only for CT, but for CTO, but for everything else, for calcium. So CT can tell you there's calcium, that's where the calcium is, it is circumferential, is there full moon calcium? There's this one feature on the angiogram called the full moon, which is essentially calcium replacing the whole circumference of the vessel, that we know it's going to be much more hard to open. You have to go extra plaque, as we say, you have to re-enter, and the risk of perforation goes up, success goes down, complications go up. So this is a very, very useful thing to find, and it's very easy to see on CT. Very, very easy to see. And the third part that CT is extremely good is the distal vessel. In the past, when we used to do less CT, we were saying, I'm going to do it in cases where I don't see the distal vessel clearly, because sometimes we don't understand the collateral circulation to the vessel. And CT is excellent for that, can tell you where is the distal vessel, how big is the distal vessel, and can help you understand what is the chance of getting in there or not. So both proximal cap, occlusion length and lesion composition, quality of distal vessel, CT is excellent. And that's why I think the CT scores are better in predicting than the angiographic scores. But again, the one caveat of CT is the collaterals. CT will see the big collaterals, but the smaller ones, it just doesn't have the resolution to be able to give you high resolution for especially the smaller collateral vessels.
No, I agree. That's very helpful, and I guess you alluded to all the criteria and information that we want to extract from the CT. I guess the question now that I'm sure people are interested is like, well, again, we have a positive trial now for like 4 years, but there's clearly a barrier that people have not implemented this into clinical practice. I mean, I think we almost by name know the handful of people that are actually using CT on a routine basis to guide their CTO PCI. I know you're one of them. There are other people like Farouk Jaffer, others that are doing this, but I would almost bet that most operators are not doing this. And I feel, I mean, my perception of this is that I think people are still struggling to like, I mean, this is great, but I have no idea how to extract this information myself. So I guess there's two routes, right? I guess one is either you're able to, leverage a robust relationship with your cardiac imagers and educate them about everything that you said, like I want that information, can that be reported, or can that information be provided to me? I guess you can go down to the CT reading room, and with your radiologists or cardiac imagers, try to walk through each CT. I mean, of course, there's some barriers already just by saying that, time and finding that person that was going to help you through that. And the last option is, do we train ourselves to look at some of this information? What has been your journey? I can tell about my journey, but maybe what has been your journey, and how do you think people? Again, we have a randomized trial. We know it helps. People are not doing it. What's the disconnect here?
You're absolutely right. And I think a big part of this is that CT, at least for me, and I know many people interventionalists right now, it hasn't been part of the training. So it was always this black box, right? I would go down, and we were very fortunate. We have amazing imagers, John Lesser, Cavalcante, um, Chen. We have such a good group here in MHI. So we have an extremely high level, and we go down and they explain to us, this is the vessel, this is the core. So it makes it very, very easy. And that's what actually I have been doing for a long time since I got to the MHI 9 years ago. But I think it's a different level when you start understanding yourself how to look at the images, how to look at things, because sometimes some of the things that you want to look at is not exactly obvious to the imagers who read CT day in, day out. I will admit that, again, we're so privileged right now. When I get the CT report, today's case, they will say, hey, it's a CTO, clear proximal cap, length 14 millimeters, a little calcium on the distal cap, consider undergrade wiring. I mean, the imager goes even to the extent and say, hey, you know what? This looks good enough. Use undergrade wiring, which obviously it's an extremely level, these are amazing people who are very experienced in this, but can really make a difference. And I don't know, your experience, I mean, you've done a lot of CTOs there as well, and you've done the CT. And you understand CT very well because you have so much experience now with both the standard software and the AI software. But what has been your experience in terms of, looking at it yourself versus collaborating and looking at it together with the other part of the group?
I mean, I think this is an evolving field, and similar to our prior episodes, if you are listening to this episode and you're like, oh, this is great, I want to take this on and explore the opportunities of CT to guide PCI, including complex lesions such as CTOs, I think probably, same as you, I think probably the number one step is to go and talk to your imager, and understand, what softwares, how to look at the data. You just to get the 101 and get a lot of their advice in how to look at this. Now, as I said, this is an evolving field, and I think as we speak, there's a lot of evolving, ways to interact with the data in more facile methods. So increasingly, and I think this will just be the way of the future. This information will be provided to us as interventional cardiologists to interact in a very facile way. That I don't think that we will necessarily need to be level 2, 3, board certified CT readers to get some of this criteria. I mean, remember, these CT readers, they're looking at everything, right? They're looking at the valves and the left atrial appendage and looking for congenital anomalies. And I mean, they're looking at everything. They're doing a full comprehensive CT report. Whereas us in corner interventions, as you pointed out, we just want the few elements. And I think as we move forward into the future, these elements will be provided to us in ways that we can, extract that data more easily in, like, let's say, like purpose-built tools for interventionalists to support CT-guided PCI initiatives. So I think this is an evolving field. But again, for the listeners, if you say, how do I get into this? I would say probably going to your imager, as you were alluding to, is the number one way to go. Something that I want to ask you is, how do you do this? Is this something that you would say you put in the request, order CT, and you put in the comments, please describe, for this is for CTO PCI planning? How does the imager know that they must describe this to you? And for the listeners, is this something that you put in the order? Because I would guess that they see CTOs all the time, but maybe it's not being done for CTO PCI planning. So you specifically request this?
Yes, and this we do. And this has been probably a very important step because these cases are often very complex. A lot of calcium, a lot of blooming artifact, and this can take quite some time from them. They have bypass, they have grafts, they have a lot of things that can be difficult to describe. So we always say this is for CTO planning, which has two effects. One is during the actually performing the CAT scan, they increase the KV, so they make higher energy on the scanner, so they get better quality images. Gives slightly more radiation, but it is important for these very complex cases because if we save some time from the actual performance of the procedure, we end up being better overall on the radiation dose. So that's one thing on the doing the procedure. So these are better quality scans than the average. And number two, then the reader knows that we're trying to understand how to cross from point A to point B. So they focus a little more time and they give more practical information on what's the lesion length, is there calcium, there is not, is there tortuosity. So they actually give us more practical information, like the one I mentioned to you, try wiring here because it's a short CTO, versus having the other components that are maybe less important for planning the CTO PCI. But I also know that you have a great paper that is hopefully coming out soon on using AI for looking at CTO planning. And what has been your experience with that? How can AI help, and would that replace eventually the cardiac imager?
Yeah, I mean, I don't think it will replace the cardiac imagers, but I think we need to be humble about the fact that why has there been a barrier and lack of implementation for something that we know helps our patients and that we have a randomized trial. And I think one of those elements would arguably be that we have had challenges in interacting with that information in an easy way. So yes, to your point, something that we've been investigating and exploring is that now there are tools, like such as like AI-QCT, that pretty much will give you automated detection of CTO for diagnosis. There are other tools, similar. I mean, like you can get this with 3D models from FFRCT that will tell you that there's a CTO. But this one's particularly for AI-QCT. The particular advantage is that it will give you a shaded, length of the CTO. And this is something that we've been exploring. And the particular advantage that we see moving forward into the future is that this just makes it easier for us to interrogate that information, understand the length of the CTO. You can easily look at the cap. Something that going back to the prior episodes and just to reinforce some of those educational components, would be those multiplanar reformations, that MPRs that we talked previously. So it's the same thing. You would be looking at that, multiplanar reformation, and similar to angiogram, you will be trying to say, is this tapered? Is this ambiguous? But I think the fact that it's now that it's like almost like, hey, here's the AI detected CTO. It's right there in that location, and it is this length, and it's assisting you with understanding where that is, providing you the right data set at the upfront that you have to look at. It just makes the information more digestible for us. And I don't think the aim is for us to be that level 3, dual boarded interventional cardiologist and CT boarded, person. We just need to figure out how can this information be provided to us so we can interact that in a way more in an easier way. But this is, as I said, this is rapidly evolving, and this is something that we're using in our clinical practice. I mean, you've been using it too. It's nothing that I would say it's investigational. These tools are out there, and it's actually, I think, a very exciting time for coronary interventions, including CTO PCI, because now we can look at this data more easily.
Absolutely. So I think, again, it's been a journey. The CT for CTO planning has been tremendous. We also sometimes use it after the procedure. For example, if there's a complication, specifically in previous bypass patients, sometimes you have loculated hematomas that cannot be seen very well on echo, so it can be very useful after the procedure as well. But the predominant role has been on planning, and I think hopefully we'll have a bigger group and a larger group that is interested in using this specifically on the CT, and even have eventually a specific CT for CTO trial done in the US, potentially even using AI and other novel tools to make it easier and more easier to implement.
No, I was gonna say, so I agree with you, and I'm sure we could talk about this forever since both of us are very passionate about this issue of complex PCI, CTO, and CT. But as we wrap this up, something that I want to ask you, because I know you've done work in this area, and this is the other aspect. We've talked about this for diagnosis. We've talked about this for pre-procedural planning, but how about intraprocedural? Because there's been a lot of interest in now this issue of CT co-registration, and something that I think it's particularly helpful is that if you get from the CT the course of the vessel. I think that, you told me you do, you've done this for years, and something that I think it's a challenge, particularly when we think about operators that do 200 CTOs per year versus that one that does like 50, is where should I push this wire? Is that the right direction? But with CT, you can understand the course of the vessel. Is this a tortuous RCA? Is this a little bit more, straight, standard anatomy? So with the CT, you can get that anatomy, and now you can pretty much get it in your lap. And I know you've done some work with the CT co-registration yourself, Farouk, and actually in the ongoing P4 trial that it's randomizing patients to CT versus IBIS. CTOs are actually allowed to be enrolled in that trial. In this one, you'll get a 3D model next to you. It's not an overlay. It's next to the screen that will display to you where the CTO and the course of the vessel is. So just to touch base on this, because I think there's the whole aspects of pre-procedural planning, but now there's the components that you can get now, the CT live guidance during the procedure. You've done this before. How do you see this moving forward?
Yeah, absolutely. And as you said, there's been a system available for a long time. There are some issues. For example, the central lines that you see are not moving with the coronary angiogram, so it's a little harder you have to have some interpretation, but it's been very useful. The key thing is, as you mentioned, number one, to look at the wire course. Is the wire going in the right course, or is it going on a side branch? Or we've seen it very useful. For example, it goes up an occluded bypass graft, and you're wondering where the wire is going, and the CT can help you clarify that. That's one thing. The second thing is it can help you choose your re-entry zone. So when you go extra plaque, sometimes it's hard to get in, especially in the very calcified areas. So based on CT, you know exactly where the calcium is, so you can choose to re-enter in an area that is much less calcified to increase your chance of success. So the intra-procedural is great. I think it's been getting better and better, and we'll be seeing more of it in the years to come.
It's perfect. So again, my soapbox on this, and this is, we need more data, but I think of all the areas of CT, CTO is an area that actually is relatively rich in the number of publications out there, as you said, for diagnosis, for AI, for core registration, for scores, KCCT, RECTOR, J-CTO from CT, and even a randomized prospective trial. So I would argue my 2 cents of this is, when you think about the hybrid algorithm that says start with dual angiography, I would say start with a CT. That would be my 2 cents. Maybe that's too provocative, but I would say that's how we should be thinking about this. And I think there's many opportunities, and I think hopefully we can all learn together how do we interventional our cardiologists interact with this information, learn how to extract it, and also how to partner with our imagers to get this information. Any closing comments, Manos, for our listeners?
Yeah, thanks, Yader. I think this was beautiful today. A lot of great points. And just to summarize, CTO is a very complex field. No matter a lot of advancements, equipment, everything else, but still we have this gap, and there's a big gap between the experienced operators and the less experienced. And I think CT can be one of the means, maybe not the only one, but can be a big one, that we can try to bring up those operators who are less experienced to get better results, better success, and better safety. It does take practice. It doesn't happen overnight. It does require familiarizing yourself with reading, how you implement it in the day-to-day. But it is a phenomenal area, and we'll see many more developments, and I think much more PCI and interventionally oriented software that can help take this information and make it practical and actionable. So great area for everyone listening to this. There is a lot of opportunities to learn, both through seminars, webinars, looking at what has been published already. And again, I'm looking forward to Yader's specific paper on CTO PCI for CTO PCI planning. But this is definitely an area worth planning. It will make you a better operator and have better success and lower complication rates.
Great closing comments, Manos. On a practical level, I think CT is so helpful because we can allocate the complex cases to you, and I can find the short taper ones for me to do them. So,
no, I think soon it will be time for me to retire. So I think it's time to shift those cases to you. So no such luck. But again, it's been great. Thanks to everyone for listening, and look forward to seeing you on the next Coronary Corner by SYSTOLE.
Thank you to all for listening. And if you enjoyed this episode, just visit systole.live and subscribe to our page to see our content. Thank you, everybody.